My name is Akinsanya and a bit of housekeeping before we move on to our lectures. So we are going to be having a Q&A session at the end of the presentation. So you can share your questions and comments in the chat box below. And I would like to remind those of us that are yet to register for our upcoming conference that Lagos will be hosting us this year. And the topic is New Frontiers in ART, the Roadmap to the Future. So for doctors, kindly register. The fee is 250,000 for those of us that missed the early bird. For non-joint residents, it is 100,000 naira. I would also like to remind us to submit our abstracts, and then the deadline for that submission is the 31st of July, 2025. Kindly follow us on all of our social media platforms, on LinkedIn, on Instagram, on Twitter handle. Just follow us on our Instagram and our Twitter pages. Thank you very much. Over to you, Prof.
Thank you, Femi. Greetings, Nigerians and members of the global community. Thank you, AFRH, the Central Executives, the Training Committee, the moderators and the co-moderators, and all that has my co-presenters and everyone. Thank you very much for joining us this afternoon. I'll be taking a part of this presentation today, after which my respected colleague is going to take the other part. We'll be taking an overview of ART stimulation protocols, updates, and current practices. And I'll be attempting this presentation using the following outlines. ART begins basically from ovarian stimulation. And ovarian stimulation has to do with controlled use of hormonal medications to induce multiple follicular development in the ovaries. It is a crucial step in assisted reproductive techniques like in vitro fertilization. And ART accounts for about 1 to 3% of annual births globally, with over 10 million babies born from IVF in the past 3 decades, and with over 500,000 IVF deliveries annually. In Nigeria, we have a little bit of hazy data, and the major reason is because of our poor updates of our registry. But be that as it may, as of 2013, we have over 40,000 babies have been born through in vitro fertilization, and this continues to increase as the country increasingly recognized as a hub for ART. A study showed higher rates of live births from the ART in Northern America, about 39.2%, compared to that in Europe, giving a value of 31.5%. Japan has one of the highest recorded ART, and the catchword there is recorded. It's not as though other places are not having high values, but I think Japan has one of the best practices when it comes to recording their success rates. So it has one of the highest recorded ART practice rates, with 1 in 16.7% births conceived via in vitro fertilization. Challenges in data collection, as I earlier mentioned, it has made it difficult for us to provide precise incidence in figures when it comes to the Nigerian situation. And this has to do with the poor data update in the registry. The key goals of ovarian stimulation or the stimulation protocols has to do with the following, and I want us to bear this in mind while I continue the presentation as I examine each of the identified protocols. The main thing here is for us to overcome ovulatory dysfunction in some patients that have this problem. And then we want to maximize oocyte yield in terms of numbers and the quality of the eggs that are being collected at the end of the stimulation. We also want to minimize side effects such as ovarian hyperstimulation syndrome, and we want to personalize the treatment for individual patient needs. The client selection process is key in this process. And of course, after doing your general assessment, history, physical examination, and conducting of relevant tests, one should be able to say with some comfortable precision the ovarian reserve markers such as the anti-Mullerian hormone, the antral follicle count, which is often assessed from transvaginal scans, the basal FSH and LH levels, that's follicle stimulating hormone and luteinizing hormones. Of course, the patient age is key in whatever assessment that we're doing. Then we want to consider previous IVF history and the response, egg counts, what stimulation protocol was used, what dosages were used, what medications were used, and what were the adverse outcomes, if any. Underlying infertility diagnosis, as the diagnosis may affect the kind of protocol that may be used, as the case may be. The risk of ovarian hyperstimulation syndrome, and patient's preference and compliance. The types and classes of medications used include gonadotropins, which are essentially in 4 or 5 classes, follicle stimulating hormone, which can come in the recombinant, which is the purest form, and we have the highly purified FSH, the purified FSH, and the human menopausal gonadotropin. And then, of course, we are beginning to have formulations of luteinizing hormone. The purpose really is to directly stimulate follicular growth, and oftentimes dosages start from 150 to 225 when it comes for normal responders, international units per day. We have 300 IU majorly. Very rarely we go up to 450 international units per day for poor responders, very rarely. But mostly 300 IU is the benchmark. Then for high responders, we have starting dose and maintenance dose of up to 100 to 150 IU per day for high responders. The gonadotropin releasing hormone agonists come generally in 2 forms. We have the daily injections and we have the depot. And examples of these include the liprolide, Lupron, buserelin, and goserelin. And the purpose of this is to downregulate the pituitary gland to prevent premature LH surge. We also have other classes of drugs such as the GnRH antagonists, such as the ganirelix, cetrorelix, cetrotide. And the purpose of this is to block GnRH receptors immediately to prevent premature LH surge, offering a shorter protocol. Then other agents such as the human chorionic gonadotropin, which are used for the maturation process. To hasten it, we have the progestins, which are employed in the progestin primed processes. We have the antibiotics for prophylaxis for those who have it as a protocol. Of course, I've already mentioned the human chorionic gonadotropin, and the main purpose of this is to trigger final oocyte maturation, mimicking the natural LH surge. We also have oral medications less commonly for full stimulation, such as adjuncts, like antibiotics, prophylaxis, supplements like folates. Then we also have some of these medications that are oral in nature, clomiphene, citrate, letrozole, especially when one wants to consider minimal stimulation. Now, the purpose of this table here presented is for us to look at the differences between the 4 main types of gonadotropins. The recombinant FSH often is the most expensive, and it's because of the way it is produced through genetic engineering, recombinant DNA technology, and of course, it is almost the purest form of FSH, about 99 to 100% pure, and then has very minimal immunogenic activity, and so it can be given subcutaneously. It's often widely used, but one of the limitations is the cost, but the dosing is often precise and allows for batch-to-batch variations. I mean, there's little batch-to-batch variations as the case may be. Then with highly purified FSH, and the human menopausal gonadotropin, most of them are often derived from the urine of menopausal women. And then the decreasing order of purification is what gives rise to the presence of the LH in variable quantities as you go down the charts. Of course, the most LH containing class is the human menopausal gonadotropin, and it has this in a ratio of 1:1. It can be immunogenic and of course, and can come down with some form of allergy, and that's why it is often administered intramuscularly. So this is just a general overview of this table of the different types of follicle stimulating hormone or gonadotropin, which I'm going to be making further comments on then later on in the presentation. So now let's go down to the stimulation protocols proper. We'll begin with the GnRH agonist protocols, of which the long protocol or the long down regulation protocol comes to mind. We have the GnRH agonists starting at day 21 classically, just 7 days or a little bit more for patients who have regular 28-day cycles. The aim of this is to introduce the GnRH into the woman's system so that just shortly after the menses comes up, down regulation is properly established, the pituitary gland is well down regulated before one now begins to introduce gonadotropin 7 days after the onset of the period. We also have a less popular day 1, day 2 long protocol. One of the things that made this less popular is because oftentimes it comes down with a number of cysts, which make down regulation difficult. So most people prefer to stick to day 21 long protocol. The advantages are as follows: the excellent pituitary suppression, as earlier mentioned, predictable response, and higher oocyte yield in some cases. The literature is actually not so, when we review the literature, you will see not much statistically significant difference when compared to the short protocol. The disadvantage mainly is because of the duration. It's quite longer. And of course, because it's quite longer, there is the possibility of using more doses of GnRH analogs. So it increases the costs. And then, of course, there is some minimal risk compared to the other protocols of increased risk of OHSS. The ideal candidates are for good responders and younger patients, not very good for older people or for poor responders. Then we have short protocol or the microdose prompt protocol. The mechanism of this protocol essentially is to introduce the GnRH agonists, starting at about the same time with the gonadotropins at the beginning of the cycle when the woman sees her period, and utilizing the initial flare effects. The main advantage is that it's shorter, it's cheaper, and it's beneficial for people that are anticipated to have poor response and for older women. The disadvantage mainly is that it doesn't have as very excellent pituitary suppression when you compare with the long protocol, and it has a higher risk of premature LH surge in some cases. The ideal candidate, as I've mentioned already, is there stated. Then we have the antagonist protocol. The mechanism essentially has to do with gonadotropins being introduced on the second or the third day of the cycle, and then antagonists are added later on, flexible or fixed schedule, depending on what suits the clinician. Sometimes some people prefer to introduce it when the leading follicles reach diameters of 12 to 14 mm, or the E2 levels, that estradiol levels, rise significantly to prevent premature LH surge. The advantage of this mainly is that it's shorter in duration, there is less gonadotropin consumption, and there's reduced risk of OHSS, and it's essentially more patient-friendly. The major advantages include that it potentially has higher risk of premature LH surge if not well timed and well monitored, and may yield fewer eggs in some cases when compared to long agonist protocol. The ideal candidates are for majority of the IVF patients, particularly those that are at risk of OHSS or preferring shorter cycles, or for egg donors, as the case may be. Recent trends actually stem from the above explanations. We're beginning to look at people beginning to tend to milder stimulation protocols to reduce the number of eggs, and by doing so to reduce the incidence of side effects or complications such as OHSS and the problems that attend it. So we have the mild stimulation protocols which come in different forms. Some people use low dose FSH, very low dose as low as 75 on a daily basis. Some others begin by introducing oral medications such as clomid or letrozole, and then eventually and monitoring, of course, and then introducing smaller doses of FSH or gonadotropin, as the case may be. The advantage is that it has reduced medication burden and, of course, lower costs, lower risk of OHSS, And then the disadvantage is that fewer eggs can be retrieved, which has a high risk of cancellations. The ideal candidates are women with good ovarian reserve who prefer less aggressive approach, or those with very poor ovarian reserve who might not benefit from high stimulation. Natural cycle IVF is beginning to gain some popularity, especially when we review the side effects such as OHSS that plagues clinics and can be fatal in some cases. The mechanism of action just generally employs the use of endogenous hormones that the woman has in her body. There is no ovarian stimulation done with exogenous drugs. It relies on the single naturally selected follicle, which may be one or two. The advantage is that no medication side effects, lower cost, no HSS risk. Disadvantage again, the chances of cancellation rates, low oocyte yield, and the oocyte that may be yielded may be of low quality. So that causes the high chance of cancellation and of course disappointment for the patient. The ideal candidates are women with regular cycles who prefer natural approach or those for whom stimulation is contraindicated. We have the progestin primed ovarian stimulation, which was I was privileged to have it presented last year during our AFRH in Abuja. This has to do with introducing progestins. A very good example is oral medroxyprogesterone acetate, which is used to suppress LH surge and allowing gonadotropins to be administered concurrently. Embryos are typically frozen, and the reason is because of the poor endometrial preparation that comes with it. The advantages generally include the fact that most of the medications are orally administered. It avoids daily injections of the GnRH, buserelin, of which buserelin is an example. Potentially lower costs and good control of premature LH surge. Disadvantages, of course, because of the poor endometrial preparation, is to freeze or it can be employed for use of egg donors. So, of course, it's a very good protocol for egg donors, as the case may be, or for people who are not ready to have their embryos transferred in a fresh cycle. Other candidates are for those for PGT and for those who are at risk of OHSS. Now, something is being entertained. It's quite trendy for now. And that banks on the fact that, we're moving away from the traditional thinking that most egg recruitments or follicular recruitment. The way theory essentially says that we have different recruitments of eggs or follicles all through the periods of the cycle or all through the times of the cycle as against what was previously follicles that can be taken advantage of. Most of the times in our practice, you will discover that after egg follicles that didn't come up, and it's because, so to speak, those follicles were not in the particular phase when the gonadotropins were coming into the system. So what this is saying is that you can stimulate at any time of the cycle. And that is essentially what this recent trend is saying. And recent animal studies and human researches have shown that this is possible stimulation at any point, and it is advantageous for time-sensitive situations like couples who are coming into the country from outside. They are not yet seeing their period. They have limited time to stay. What this is saying is that you don't need to necessarily wait for her to see her period, especially if she is not doing a fresh transfer. One can start stimulation. And even from our clinical experiences locally, we have seen that this has been successful in selected cases. It has increased efficiency, flexibility, potentially more oocytes, such as is the basis for duostim, which my senior colleague will talk about later. The major disadvantage is the endometrial asynchrony for implantation. And so one either does freeze or and is quite good and relevant for egg donors. Other trend has to do with the combination of the different classes of gonadotropins. Now, of course, before now, you find that the teaching is that use one class of gonadotropin. If you want to stick to recombinant, stick to recombinant. If you want to use purified, stick to it and use it all through the cycle. And if you want to use human menopausal gonadotropin, just stick to it. Recently, thoughts are beginning to emerge and researchers are beginning to give credence to the fact that you can actually combine different classes of gonadotropins to achieve different aims. And one of those schools of thought include the use of recombinant FSH and HMG together concomitantly. And the main advantage is the LH activity of the HMG helps to improve maturity of the eggs. Some other people say no, you can start with recombinant FSH in the early phase of the stimulation because it's purified, it's recombinant. It helps to recruit a maximum number of good midway and start with HMG to improve follicular maturation because of the LH activity in the HMG. Some people combine this together, some use it sequentially, beginning with recombinant FSH and finishing up with HMG, and then, of course, triggering before egg collection. The studies that have been found in this nature are, well, not too significant, but good results have also been found. Even though not so consistent. Suppression, that is people who don't have hormonal, when you do hormonal assays, their LH levels are quite low, then the HMG will be profitable for such people, especially elderly people, poor responders, and people who have not performed well with the other protocols. This has been found to be a good approach for treating such people. So we have two general classes, concomitant use or sequential use. In concomitant use and sequential use, I've already explained this before. Now, there's the role of monitoring hormones and folliculometry. There is guidance for medication adjustments, especially with monitoring of hormone levels during the process of ovarian stimulation. And the major hormones are E2, that is estradiol, luteinizing hormone, and progesterone. And sometimes this helps to indicate the adequacy of the timing of egg retrieval and not just relying solely on follicular sizes on folliculometry. It helps to get the alerts for imminent OHSS, and it helps you to take precautionary measures as the case may be. E2 also helps to assess uterine receptivity, as it helps you to time the adequacy of the time for embryo transfer. Rising E2 indicates good follicular response versus the increased levels in OHSS when it goes above the adequate levels. LH plays a role in oocyte maturation, and monitoring of LH helps to prevent LH surge, premature ovulation, as the case may be. As you may find on some occasions at the time of egg collection, you may find a good number of your follicles luteinized. The reference levels actually differ from place to place and depends on the protocol that you are required to adopt in your particular center. Progesterone levels are low in early follicular phase, and a premature rise can indicate asynchrony in follicular development or a less favorable outcome. FSH is less frequently monitored but may indicate adequacy of intake. For the SCG, human chorionic gonadotropin, which is used, as I earlier mentioned, for the maturation of the follicles before egg collection, is mostly administered in a dose of 5,000 to 10,000 IU as a single dose. Recombinant FSH is also available as doses of 250 micrograms, which have almost the same strength as 10,000 or 5 to 10,000 IU of the regular formulations. Some studies have explored daily low dose of HCG supplementation, 550 to 150 IU per day from the start of stimulation alongside FSH to potentially improve embryo quality or ovarian response. But this is generally not popular and subject to further research. The basic routes for administration include subcutaneous, intramuscular, and nasal spray, especially for those who are at risk of OHSS. The timing is usually given when follicles reach maturation sizes of not more than 18 millimeters in GnRH antagonist protocols, or 18 to 20 millimeters in diameter for GnRH agonist cycles. Egg retrieval is typically between 34 to 37 hours after ACG injection and may be also used in luteal support, but one should caution, especially when people are at risk of OHSS, to mitigate the dosing as much as possible. The complications of ovarian stimulation are as follows: OHSS, which is the most feared complication, multiple pregnancy, ectopic pregnancy, which is quite rare but can happen. From egg retrieval, you can have hemorrhage, infection, injury to contiguous structures, ovarian torsion, sometimes requiring ovarectomy. From side effects of the medication, mood swings, headaches, breast tenderness, bloating, pain at the injection site, rashes, and other forms of allergy. Then, of course, you have cancellations. In conclusion, ovarian stimulation is the cornerstone of modern fertility treatments, significantly increasing the chances of conception by promoting egg development. Individualization of patients is key in this process. And so a thorough clinical assessment cannot be overlooked. It is important to watch out for complications such as OHSS and be careful to monitor patients well during the process. Future research may focus on long-acting gonadotropins, milder stimulations protocol to prevent unwanted side effects. These are my references, and I thank you so much for listening.
Okay, thank you, Dr. John Ekweani, for that presentation. It was quite so. At the end of the discussion, at the end of the 22nd, we'll be introducing the next speaker. The next speaker is a well-known person. He's Dr. Femi Akinsanya. Dr. Akinsanya graduated from the famous University College, where he also obtained a master's degree in human reproduction and development from the famous University of Bristol, the United Kingdom. He's a fellow of the West African College of Surgeons, the Faculty of Obs and Gynae. He obtained fellowship and diploma in minimal access gynecological surgery from France and India, New Delhi. He also bagged a fellowship in robotic surgery from the World Laparoscopic Hospital, Gurgaon, India. Most of you know about the Professor Mishra, the famous Mishra. Until lately, he had been a lecturer at OAU, Obafemi Awolowo University, College of Health Sciences. He's also a lecturer at Olabisi Onabanjo University, Ago Iwoye, and also a consultant obstetrician in the teaching hospital, the Olabisi Teaching Hospital, Sagamu, Ogun State. He has authored and co-authored many publications in top peer-reviewed journals, both locally and internationally. He's also an astute external examiner at various tertiary institutions. With almost 2 decades to his credit, he has practiced as a reproductive endocrinologist and fertility expert at the Magnificent Center for Fertility, Gynecological Endoscopy, Women and Newborn Health, and the place is Healing Spring Hospital in Lekki, Lagos State. He is a member of many local and international associations and societies. Mentioned is Nigerian Medical Association, Society of Gynecology and Obstetrics of Nigeria, SOGON, Association for Fertility and Reproductive Health, AFRH, Association of Fetal-Maternal Medicine, AFMC, American Society for Reproductive Medicine, ASRM, and International Society for Gynecological Endoscopy, ISGE. He's a well sought after as a researcher and a well-known speaker, academic speaker, both locally and internationally. At this level, please join me in welcoming Dr. Femi Akinsanya to take up the podium and give us his presentation. Thank you very much, Dr. Akinsanya.
Thank you very much for having me. I joined the first presenter, my colleague, to thank AFRH for this privilege to give this presentation. Without much ado, I'll be talking about dual stimulation protocol in ART practices. And I hope you can see my slide. Hello?
Yeah, we can see your slide, Dr. Akinsanya. Please, we have limited time. Keep to time, please.
All right.
We have just 25 minutes to make our presentation, sir.
All right, so the outline of the discourse is as shown in the slide. Basically, dual stimulation is an IVF protocol popularized by Kwang et al. And his view was that of a transformative look to improving the outcome of ovarian stimulation in poor responders. And basically, it involves stimulating the ovaries twice in the same menstrual cycle. That is in the follicular phase and immediate luteal phase, with a primary aim of enhancing oocyte yield. Unlike the traditional IVF approach, dual stimulation involves 2 cycles of stimulation and 2 oocyte retrieval during the same menstrual cycle. And the primary aim and objective is to maximize the number of follicle retrieved in the same cycle, and also to increase the chances of successful fertilization and increase the number of utilizable blastocysts or embryo that is generated. And basic indications for this type of protocol include patients with low antral follicle count, low AMH, and patients with very high FSH, and poor responders, and patients that are, that have urgent need to preserve fertility, particularly patients with oncologic indications to preserve fertility. And as we're all familiar, and it was just discussed, in conventional IVF protocol, which premises on stimulating the ovary in the follicular phase, in this patient, they tend to have this protocol tends to be inadequate and very challenging in this patient. And the reason is not far-fetched. It's simply because they have limited number of oocyte recruitment, and the protocol could be prolonged, and and then in order to achieve enough oocyte, and a lot of them tend to have suboptimal response with a conventional protocol. What is actually the concept behind dual stimulation? Previously, we've been erroneously taught to believe that follicular recruitment occurs only once in the follicular phase of the menstrual cycle. But ample evidence actually show now that there are multiple waves of follicular recruitment occurring in a single menstrual cycle. About 2/3 of women in the reproductive age group tend to have about at least 2 waves of follicular recruitment in the menstrual cycle, and about 1/3 could actually have about 3 waves, follicular waves in the cycle, and hence their cycle could actually be longer. And then with all this going on, hormonal cues from the brain will allow only one follicle to become dominant, while the rest are pushed into atresia, or they become apoptotic. dual stimulation actually leverages on this multiple follicular waves and the fact that in the luteal phase, there's progesterone-mediated LH rest, suppression. And it leverages on these two basic pinnacles to rescue multiple follicles that will otherwise have become atretic. And hence, oocyte development and maturation, we have come to understand, is independent of menstrual cycle phase. It doesn't matter when, at what phase the patient is presenting. This process is ongoing in the whole menstrual cycle. And as a result, ovarian stimulation can actually be initiated at any cycle phase. And one doesn't need to worry about having to wait for follicular phase before stimulation can actually start. And that has brought up the concept of random start at any time the patient presents. Now, in the same way, one can actually separate the menstrual cycle phase, from stimulation phase and from implantation phase. Once one has a good grasp of this concept we're talking about, one can have complete disarticulation of menstrual cycle phase, ovarian stimulation phase, and embryo transfer phase. With that understanding, there's a lot that can actually be done for this patient with that we have tagged poor responders. And then basically, dual stimulation may follow either of the two steps. One can begin in the follicular phase and stimulate the patient, followed by oocyte retrieval, and then restart the stimulation in the luteal phase. Or one can actually begin stimulation in the luteal phase and then followed by oocyte retrieval, and then restart in the precipitant luteal phase following the egg collection. And the reason for this is that once we understand the basic concept in the luteal phase protocol, which actually involve establishing the baseline of this patient within 2 to 7 days after ovulation, and this is followed by ovarian stimulation, either using any of the molecules that have been described by my colleague. And then once has achieved about 12 to 14 millimeter size follicles, then one can then introduce the GnRH antagonist or an exogenous progestin, and then this is followed by ovulation trigger. There are categories of patients that is expected to benefit from dual stimulations. And these categories of patients are patients that one needs, the shortest time, and also one needs to amplify oocyte yield. An example of such patient will include oncologic patients that requires urgent fertility preservation. And we're all aware that annually over 1 million of them are actually, are diagnosed newly. And then patients that are poor responders, depending on which of the criteria one is using to classify them, are also expected to benefit from dual stimulation. And also patients undergoing pre-implantation genetic testing, because one needs to be able to pull embryos, together in large volume and then be able to test for aneuploidies and then reducing the need for multiple stimulation. If that is the goal, then dual stimulation offers a great benefit. And what are the expected outcomes of dual stimulation? It's been shown that there are similar fertilization and blastocyst generation rate in each phase. In fact, the second stimulation tends to increase the number of oocyte retrieve, and probably, with a view to yielding at least one euploid blastocyst and also have a live birth outcome. One should also be aware that the luteal phase stimulation in dual stimulation tend to show higher E2 level, higher progesterone level, and LH level. Pregnancy rates appear to be higher for embryos that result from luteal stimulation, and significantly, oocyte yield tend to be more in such patients, it's been documented in some publication that may be as high as 3 to 3.5 more metaphase 2 oocyte could be retrieved. Also, the timelines are reduced, waiting period, and the time taken to achieve the goal are also very reduced. Inconsistent reports have actually been shown as regards live birth rate, but dual stimulation tend to satisfy the demand for optimizing flexibility in ovarian stimulation and also improving outcomes in IVF. Compared to conventional protocol, it doesn't seem to be the miscarriage rate doesn't seem to be different. It appears both appear comparable. Are there safety or clinical considerations that one may be worried or concerned about? Obviously, yes. It involves monitoring, intensive monitoring. You want to minimize the risk that could happen. For example, OHSS in some classes of patients accessing this treatment protocol. Although in patients with poor responders, OHSS incident is very low in them, but particularly if GNHRH analog are used as triggers compared to HCG. One needs also to be aware that regular ultrasound monitoring are quite crucial, and one needs to assess E2 level and P4 level, and that will guide in dosing adjustment in this patient. And then especially oncology patients that actually have normal and they have good ovarian reserve, one needs to actually balance the dosing of this medication in them, because in them their ovarian reserve is still very good, and one needs to be aware that they also run the risk of OHSS, which if precipitated will actually make their situation worse. And then one needs to know that there's asynchrony between endometrial lining and the generation of the blastocyst. So there's usually no embryo transfer during this period. It has to be done at a newer cycle. Also, I've expressed the need to individualize dosing regimen in this patient. Also, one also should be aware that luteal phase stimulation cycles have actually been associated with undetected natural conception, in this patient at the time one is starting stimulation. That is, the chances of spontaneous ovulation and conception is also, possible. One needs to be aware, of this in this patient. And luteal phase stimulation versus conventional ovarian stimulation has shown no significant difference in the incidence of live birth, as well in the incidence of the gestational age at which delivery occurs, or the birth weight, or neonatal mortality rate, which are things that one could be concerned or worried about, engaging this new protocol. Then careful patient selection and monitoring to mitigate all the risks that we have talked about are quite crucial when employing this particular stimulation protocol. Now, dual stimulation is it's not without limitations or drawback. First of all, one needs to be aware that there is no transfer in that cycle. All embryo must be cryopreserved. You understand? Then also, one needs to be careful with a second oocyte collection, because there's also the risk of eroding into the corporal lutea, which may cause torrential bleeding. So one must be careful, when doing the second egg collection in this protocol. Also, the switch from fresh embryo transfer to a later transfer, may be another concern, because it's going to cost, and there's going to be an extra cost to doing that. And it's also, of course, one should be aware that you're going to there will be higher number of gonadotropins, that will be used in this protocol. And the laboratory staff will have to have all hands on deck, and they will have to spend more time. The doctor will spend more time, the embryologist will spend more time, and also the cost of vitrification in this cycle. Now, in the future, there are concerns and worries about this protocol, and we need to actually look at these issues, and more research needs to be done as regard these issues. For example, we need to focus the different dosing regimen. You know, some people in the initial stimulation may want to add medications like letrozole, you know, and other stuff into the initial stimulation and then take it off in the second stimulation. So there's no standardization as regards, you know, dosing regimen. So we need to come up with standard dosing and protocol regimen for this particular type of stimulation. And then what are the long-term outcomes? You know, how can we maximize that to impact positively on ART? And then there's also controversies and discussion, and since we know that where the dual stimulation is leveraging on you know, on not only on the follicular wave, multiple follicular waves, but also on the high, you know, progestin that is causing suppression of LH. Why is there still need to have an GnRH agonist or antagonist being administered in the luteal phase? Or should one still use an exogenous progestin, you know, in this second part of the protocol? These are issues that are still up for discussion, and more research needs to be done on this particular issue. There's also need to establish a scientific basis for choosing the duration between the first pickup and the start of the second one. A lot of people will want to do this between you know 1 and 5 days, you know, after the first collection. Some people will say between 2 and 7 days after the first collection. So there is no precise definite instruction on actually, do you wait for 2 days after the first stimulation? Do you wait for 5 days or 1 week after the first stimulation? So more research needs to be done. We need to look into this and come up with something definite that everybody can actually follow. And also, we need to explore the potential benefit of adding LH activity to this dual stimulation in order to enhance generation of follicles by promoting steroidogenesis and increasing androgen production, thus improving recruitment of pre-antral and antral follicles, especially in poor prognosis patients. We also need to explore the protocol's efficacy in non-poor responders, such as, you know, egg donors and normal responders, and how this can broaden its clinical use, you know, extended to other classes of patients. Also, the role of artificial intelligence-driven dosing algorithm, you know, holds promises, and we need to also look into this so that potentially we can improve oocyte yield and embryo quality, you know, when using this protocol. In conclusion, by leveraging on multiple follicular waves and time-efficient strategy to significantly enhance oocyte yield within a single menstrual cycle, dual stimulation has evoked a transformative approach that has redefined IVF with staggering benefits for a special cohort of patients. However, long-term safety data and strategy to promote equitable access are critical to broadening its applicability, particularly in our own kind of environment where resources are highly constrained. Thank you for your attention.
Thank you so much, Dr. Akinsanya, for that insightful presentation. Thank you, Dr. John Ekweani, for your presentation too. So at this point, we would like to entertain questions. So for now, I'm not seeing any question on the platform. I don't know if there is anybody that has questions based on the presentations for any of the presenters. So If we don't, then we move on with the next event before we round up the session. So I will just wait for like 2 minutes to know if a question can come up. And if there is none, we move on. Thank you once again, Dr. Akinsanya. It was quite insightful. Thank you. Okay, there is a question here. There's a question for Dr. Akinsanya. It says, which of the protocol is the best? Somebody asked a question, which of the protocol is the best to adopt? And the question was meant for Dr. Akinsanya. So Dr. Akinsanya, I don't know if you can give us a quick response to that. The question says, which of the protocol is the best to adopt?
Actually, I am not too clear whether the individual asking the question want me to talk about because whether we need to, because I talked about whether they need to still use gonadotropin agonists in the, as you know, to ensure that one does not have a premature early surge, or whether not to use. If the individual is asking about that, you know, or is asking about the different protocol, whether you're doing a long protocol or you are doing a short protocol, that question will be for my other colleague. But if it has to do with dual stimulation, then for now, most people practicing dual stimulation will still use GnRH agonists, you know, while conducting this ovarian stimulation, because we don't have enough research findings on whether one can totally rest on the natural suppression coming from the natural suppression of LH that is associated with the protocol.
Okay, thank you very much, Dr. Akinsanya. There's another question. The person asked a question on your experience. Say, does anyone have experience with progesterone prime ovarian stimulation? What has been your experience? Please, that is to Dr. Akinsanya. Your experience with progesterone prime ovarian stimulation.
All right. Actually, it was my colleague that talked about that. But what I know about my experience with progesterone prime stimulation, especially with patient with low AMH, that elderly patient that are insisting on egg donation, donated eggs are not acceptable. One can actually use progesterone to bring down the FSH a little, you know, and then that may impact on the yield thereafter when one starts giving gonadotropins. I don't know if my colleague will want to chip in one or two as well.
Okay, Dr. Ekweani, I don't know if you have anything to add. Please, Dr. John, please. Do you have anything to add?
Is it for the progestin primed
progesterone prime, yes.
Okay, yes. I think the person asked whether we have personal experiences, and the answer is yes. And of course, quite good, especially for egg donors who are not being primed for an embryo transfer. Is quite good. Has comparative what they call it, egg yield, fertilization, pregnancy rates compared to long protocol and short protocol, as the case may be. I think in my center, a resident had studied it for her Part 2 dissertation, and I think she's about to defend it, and I was privileged to be part of that study. So it has quite good egg yield, and then typically what happens is that one begins with, just like on the day 2, day 3 cycle, as one begins with the gonadotropin, the person starts concurrently with daily tablets of progestin, such as medroxyprogesterone. I think the popular brand we have around here is Provera, 10 milligram daily, and that continues up to the time of trigger and egg collect. Even up to the day of egg collection. So that's just the basic thing, and it's cheaper because you consume less of GnRH analogs, and then typically the incidence of OHSS is less compared to clients who are either on short protocol or long protocol, as the case may be. So that's just a basic summary of what the experience has been at my center. Thank you very much.
Okay, thank you so much, Dr. John. There's another question. They say, the person asked a question regarding dual stimulation. He said, are there any age limit or age consideration when using this protocol of dual stimulation? Then do you find it more beneficial or more commonly used in younger women compared to the older women? So the question is on dual stimulation. Is it preferable for the younger or the older women? So the question was not referred to any of the presenter. So I think Dr. Ekweani, you can talk more on that.
Sorry, I don't think I got the question very clearly. I think
The
I had a little
question
bit
is
of
on
networking.
dual stimulation. Is it preferable for the younger or the older patients? And what's your experience?
Okay, thank you very much. I think generally dual stimulation it's preferable for older patients who are poor responders. I think those are the what do you call it? That is why most people began to tilt towards it for poor responders. So I think it's for older patients, preferably, and for poor responders. And then essentially for people who have a shorter time of stay, shorter duration of stimulation, those are the kind of people that generally benefit more from such kind of stimulation. And it's important for me to note at this point, just like I mentioned earlier, that there is really no best stimulation protocol. Everything has to be done based on the individual patients. And that is why we cannot overrule the importance of adequate clinical assessments, which are done. And then we tailor the protocol accordingly, according to the patient's age, body mass index, hormonal indices, previous stimulation experiences, previous side effects, and then we select a protocol that will be appropriate for that kind of patient. So everybody has his own, there are different strokes for different persons. I think that's just essentially what I will have to say about that.
Sorry, if I may add, hello, sir.
Okay, okay, we'll take the last question for the day. And the question says, how do you identify the new intrafollicular count post-OPU in the second wave of stimulation? Then what is used for trigger in the first OPU?
Sorry, can you say that again? Can you say that again?
How do you identify the new intrafollicular count post-OPU in the second wave of stimulation? And what is used for trigger in the first OPU?
All right. In the second phase of stimulation, basically, when you are doing your ultrasound assessment, you've just finished a collection, and then you look at the characteristics, the ultrasound findings in those where you have just collected your follicles. The eggs. The ultrasound appearance will show some webbing and some the echogenicity are different. But the upcoming, the antral follicles, usually the upcoming new ones, number one, the sizes are different. Usually they're about 2 to 5 or 2 to 6 millimeter, and they have a clear, appearance, and they do not have internal echoes. Like where like the follicles that you've just emptied, done the oocyte pickup, so they definitely, they are smaller, and then they have, they're echo-free, on ultrasound. Then in terms of trigger, most people will either use GNHRH analog, to trigger, or they may, with or without HCG rescue, or if one is also used to administering HCG alone, the important thing is to individualize the patient and also ensure that one is avoiding those other risks that are associated with the protocol.
Okay. Thank you so much. Thank you so much, Dr. John and Dr. Akinsanya. We are so happy and so pleased at this presentation. We can't have it better than this. And just as I said last time, that it can only get better, and it's definitely getting better. So at this point, I want to call on my boss, my special boss, and our amiable president, Professor Prayer, to address the House. Thank you, Professor Prayer. You have the floor, sir.
Prof. Femi is currently not on this panel, so in his
Hello, good
I
afternoon.
would like to ask the chairman of the training committee, Dr. Lateef Akintola, can you please address the House on behalf?
Okay, yeah, thank you so much, Ekweani, for moderating. This, quite an excellent presentation, and I like the way Dr. Akinsanya and Ekweani dealt with it. There is pretty much, nothing much to add to the presentation. I just want to make one observation. You see, occasionally when you do stimulation, you can also use it for someone who is less than 35.
Yeah.
I mean, when you have normal AFC, normal AMH, serum AMH concentration, but when you now stimulate this person, then you are disappointed in terms of the egg yield, actually. In that instance, if you are tuned to that, you can give them the chance to do that again, especially if you have maybe you are retrieving less than 4 or 5 oocytes. You can also give them, you can also do dual stimulation on that. I also want to emphasize that I like the dedication that most of our members have given to this presentation. And please, all the people that have presented, the idea is that we can collate all these presentations and make it in a form of textbook, AFRH textbook, that we can all be referring to. Maybe this time while we are presenting, we can make sure that we are updating our presentation along the line, because at the end of this series, we are going to ask you to send us a manuscript of all the presentations so that we can send it to reviewers, they can review it. We can have a good textbooks for ourselves and those coming behind us. So it's a great opportunity for us to do this, please. Thank you so much, the Secretariat of AFRH. You've been excellent in organizing this, the Yeji Day, and our boss, Gensec, Mrs. Rose. So on this, I mean, at this juncture, I want to pass it back to the moderator Akinsanya to, at least give us a vote of thanks to the
thank you,
presenter.
Dr. Lateef Akinola. Lateef, you didn't recognize me. I'm the moderator.
Oh, you are the moderator,
is the moderator.
Oh, Dr. Clay
Well,
is the
thank you so
moderator.
much for your innovative idea. I'm quite impressed. I think we should be thinking towards getting a textbook. That should be the way to go. Because all this knowledge cannot just be for the sake of a webinar. It should move to the next level. And the best way to leave that legacy is to have a book that people that are coming after us can refer to. And that's the only way we can put down our names in the annals of history. So thank you very much, Dr. Lateef, for the good job you are doing. The academic arm of the organization, for me, is the strongest arm, and is the arm that gives birth to every other arm. So thank you for the job you and your team are doing. We are happy, we are impressed, and we are very grateful to you, sir. So at this point, I will call on Akinsanya Umana to update us again on the information that she earlier passed on, so that people that joined lately should be able to be abreast on the upcoming events in AFRH, most especially the submission of the papers for our upcoming annual events. So, Dr. Umana, please, can you just update the house once again before we close for the day? Thank you very much.
I would like to thank all our viewers for making out time to join this webinar. It was very interesting and very impactful. I'd also like to remind us to register for the Lagos 2025 conference. For those of us that have not registered, you can contact the Secretariat for more information. And also, for those of us that would like to present at that conference, please submit your abstracts. The deadline is 31st of July, 2025. Kindly do well to follow us on all of our social media platforms, Facebook, Twitter, LinkedIn, Instagram, so you can get updates on all of our activities. At this juncture, I'd like to thank the National Executive of AFRH for this opportunity, as well as the training committee for these very educative webinars that we have been enjoying, and the opportunity to moderate this session. And I would also like to thank my co-hosts for a fantastic job done.